Noonan syndrome belongs to a group of disorders called RA-sopathies, which are caused by dysregulation of the RAS-MAPK signaling pathway that drives cell growth and differentiation during embryogenesis. First described in the early 1960s, the syndrome is characterized by a distinctive set of facial features: short stature, congenital heart defects, and variable neurocognitive involvement. Clinicians consider Noonan syndrome important because the cardiac lesions, most commonly pulmonary valve stenosis and hypertrophic cardiomyopathy, can be life-threatening if not identified early. And the growth and learning issues often require multidisciplinary support throughout childhood and adulthood. The genetic basis of Noonan syndrome lies in heterozygous gain-of-function mutations that hyperactivate the RAS-MAPK pathway. Approximately 50% of affected individuals carry pathogenic variants in the PTPN11 gene, which encodes the protein tyrosine phosphatase SHP2. Other genes implicated include SOS1, KRAS, NRAS, RAF1, BRAF, MAP2K1, and RIT1, each contributing to a slightly different phenotypic spectrum. Inheritance follows an autosomal dominant pattern. A single mutated allele can cause the disease, giving a 50% recurrence risk for each offspring of an affected parent. Nonetheless, up to 80% of cases arise de novo, meaning the mutation appears for the first time in the child without a family history. Genetic counseling therefore involves assessing family pedigrees, discussing recurrence risk, and offering targeted molecular testing. Mutations in the RAS-MAPK cascade remove normal regulatory brakes, leading to constitutive signaling through RAS, RAF, MEK, and ERK proteins. This hyperactivation skews the balance between cell proliferation, differentiation, and apoptosis during early organogenesis. For example, excessive ERK activity in cardiac progenitor cells results in abnormal valve formation and myocardial hypertrophy, explaining the high prevalence of pulmonary stenosis and hypertrophic cardiomyopathy. In the craniofacial region, overactive signaling disrupts the migration and patterning of neural crest cells, producing the characteristic broad forehead, low set ears, and short neck. Likewise, dysregulated growth plate chondrogenesis underlies the short stature, while altered neuronal development contributes to learning difficulties and mild intellectual disability. Noonan syndrome is estimated to occur in roughly 1 in 1,000 to 1 in 2,500 live births, making it one of the more common genetic syndromes worldwide. The prevalence appears consistent across ethnicities and sexes, though some studies suggest a slight male predominance in certain cardiac phenotypes. Increased awareness among pediatric cardiologists and the broader availability of next-generation sequencing panels have led to a rise in diagnosed cases over the past decade, particularly in milder phenotypes that previously escaped detection. Population-based registries now report an upward trend in prevalence, likely reflecting improved ascertainment rather than a true increase in incidence. The phenotypic spectrum of Noonan syndrome is broad, but several features recur with high frequency. Craniofacial dysmorphism includes a wide high forehead, hypertelorism, widely spaced eyes, down-slanting palpebral fissures, low-set posteriorly rotated ears, and a short webbed neck that may exhibit a cystic hygroma in infancy. Cardiovascular anomalies are present in 80% of patients. The most common is pulmonic valve stenosis, followed by hypertrophic cardiomyopathy, which can progress to heart failure if untreated. Growth failure becomes evident by age 2, with final adult height often more than 2 standard deviations below the mean. Growth hormone therapy can add 6 to 9 centimeters in responders. Musculoskeletal manifestations include pectus excavatum or carinatum, scoliosis, and joint hyperlaxity. Neurologically, children may experience mild to moderate learning disabilities, especially in visual spatial tasks and occasional speech delays. Hematologic abnormalities, such as bleeding diathesis, due to platelet dysfunction and lymphatic dysplasia, leading to persistent edema or chylothorax, are also reported. A typical clinical vignette is a toddler who tires quickly during play, has a characteristic facial appearance, and requires supplemental educational support. Diagnosing Noonan syndrome begins with a careful clinical assessment for the cardinal facial features, cardiac lesions, and growth patterns. The revised nosology for Noonan syndrome and related retinopathies provides a scoring system that combines dysmorphic criteria with cardiac and extracardiac findings to guide suspicion. Definitive diagnosis rests on molecular confirmation, targeted next-generation sequencing panels covering the known retinopathy genes, whole exome sequencing, or single-gene testing when a specific mutation is suspected. Prenatal ultrasound may reveal increased nuchal translucency, cystic hygroma, or cardiac abnormalities, prompting invasive sampling, chorionic villus sampling, or amniocentesis for molecular analysis. Postnatal workup typically involves echocardiography, growth charting, endocrine evaluation, including thyroid function and growth hormone axis, audiology, ophthalmology, and developmental screening. A multidisciplinary team, pediatric cardiology, genetics, endocrinology, orthopedics, speech therapy, and psychosocial services, ensures comprehensive care. While the classic presentation is often referred to simply as Noonan syndrome, several genotype-linked subtypes have been delineated. Noonan syndrome with multiple lentigens, historically called leopard syndrome, is associated primarily with PTPN11 or RAF1 mutations, and presence with characteristic café olate spots and a higher incidence of hypertrophic cardiomyopathy. Noonan syndrome with loose anagen hair involves mutations in SHOC2 and is marked by soft, easily pluckable hair and a more subtle facial phenotype. Overlap with other R-esopathies such as cardiofacioCutaneous CFC syndrome, Costello syndrome, and neurofibromatosis type 1 occurs when mutations affect downstream effectors like BRAF or MAP2K1, leading to additional skin, hair, or neurocutaneous findings. Recognizing these subtypes informs surveillance strategies because, for instance, the lentigens variant carries a modestly increased risk of malignancy. Management of Noonan syndrome is problem-oriented and requires lifelong coordination. Cardiac lesions are addressed early. Beta blockers or calcium channel blockers can control symptomatic hypertrophic cardiomyopathy, while surgical valvotomy or balloon dilatation relieves severe pulmonary stenosis. Growth failure is often mitigated with recombinant human growth hormone, initiated after confirming normal thyroid function and ruling out active cardiac disease. Treatment typically spans several years and improves final height and quality of life. Neurodevelopmental support includes individualized education plans, speech-language therapy for articulation issues, and occupational therapy for fine motor challenges. Orthopedic concerns, such as pectus deformities or scoliosis, may need bracing or corrective surgery during adolescence. Hematologic monitoring is essential because platelet dysfunction can cause bruising or prolonged bleeding after minor procedures. Prophylactic antifibrinolytic agents may be used perioperatively. Regular endocrine assessment screens for hypothyroidism, which occurs in up to 20% of patients, and for lipid abnormalities that can arise later in life. Finally, psychosocial care, counseling for the patient and family, support groups, and transition planning to adult services forms a cornerstone of comprehensive management. Because Noonan syndrome is a genetic disorder, primary prevention of the condition itself is not possible. However, risk reduction and informed reproductive choices are achievable through genetic counseling. When a parent carries a pathogenic variant, preconception counseling outlines the 50% recurrence risk and discusses options such as pre-implantation genetic testing for monogenic diseases in conjunction with in vitro fertilization, allowing selection of embryos without the mutation. For families without a known mutation, non-invasive prenatal testing can screen for common chromosomal abnormalities, but targeted testing for RA-SOPathy genes requires invasive sampling, chorionic villus sampling, or amniocentesis, followed by molecular analysis. Early prenatal detection enables parents to plan perinatal care, arrange specialist follow-up immediately after birth, and make personal decisions regarding pregnancy continuation. Postnatal, newborn screening programs do not routinely include Noonan syndrome, but awareness among obstetric and pediatric providers can prompt early diagnostic evaluation when characteristic signs appear. The overall life expectancy for individuals with Noonan syndrome approaches that of the general population, especially when major cardiac lesions are identified and treated promptly. Mild to moderate cardiac disease, when managed with medication or surgery, typically does not limit longevity. However, severe hypertrophic cardiomyopathy, progressive valve disease, or arrhythmias can increase mortality risk in childhood or early adulthood. There is a modestly elevated risk of certain malignancies, most notably juvenile myelomonocytic leukemia and less frequently neuroblastoma, linked to the underlying RAS-MAPK hyperactivity. Growth hormone therapy, when appropriately supervised, improves final adult height without increasing cancer risk. Cognitive outcomes vary. Many individuals achieve independent living, higher education, and gainful employment, while those with more pronounced learning disabilities may require ongoing support. Regular surveillance for cardiac function, endocrine abnormalities, hearing loss, and psychosocial well-being is essential to optimize long-term health. The past 5 years have seen rapid advances in genotype-phenotype correlation for Noonan syndrome. Large-scale cohort studies have linked specific PTPN11, SOS1, and RAF1 variants to distinct cardiac or dermatologic phenotypes, enabling clinicians to anticipate complications based on molecular findings. Pharmacologic trials targeting the overactive RAS-MAPK pathway, particularly MEK inhibitors such as trametinib, have demonstrated partial reversal of hypertrophic cardiomyopathy and improvement of cutaneous manifestations in small open-label studies, heralding a shift toward disease-modifying therapy. Gene editing technologies, including CRISPR-Cas9 base editors, are being explored in patient-derived induced pluripotent stem cells to correct pathogenic mutations, offering a potential future curative avenue. Updated clinical guidelines now recommend baseline cardiac MRI at diagnosis, annual endocrine screening, and earlier initiation of growth hormone therapy as early as age 2 when cardiac status permits. Additionally, patient registries and international consortia are facilitating long-term outcome tracking, which will inform evidence-based care pathways for the next generation of individuals with Noonan syndrome.